Good afternoon, and welcome to the Joint Symposium on Claudication, the multi-professional team. My name is Ansi Egan. I'm a consultant vascular surgeon from Preston, and my co-chairs are...
Kimberly Farrer, vascular physiotherapist and back part exec member.
And Gail Curran, vascular specialist nurse, part of the Cambridge University network in East Anglia.
Thank you very much. Our first speaker today is Professor Marc Bailey. Marc is an associate professor of vascular medicine at the University of Leeds and is going to be talking on pharmacological interventions for intermittent claudication.
Chairman, ladies and gentlemen, thank you very much for the invitation. So we all know what intermittent claudication is. We spend a lot of our time discussing CLTI, which is quite correct, but we have to remember that the majority of PAD cases around the world present with claudication. It is a common clinical problem, and as we all know, the main issue is limitation to patients' walking distance and quality of life. The risk of progression to a major limb-threatening event is very low, but they do have a high cardiovascular event rate. Patient priorities in this space, as we learned this morning in the PAD session, are not necessarily aligned with ours as clinicians, but what seems to be particularly important to patients is how we can improve their symptoms and reduce disease progression. So what could we do if we take a step back? Well, we could revascularize, we could get the patients to collateralize, we could try and vasodilate the vessels that we've got, or we can try medical therapies to reduce or reverse the underlying disease process. For a long time, we've tried intervention. There are many, many trials I could show you. This is fairly typical. This is the CLEVER study. This is looking at a comparison between cardiovascular secondary prevention or optimal medical therapy, OMT and exercise, and OMT and stent revascularization. So the medical group is blue, stent is red, supervised exercise green. And what you see is this fairly typical response over the first 6 to 18 months. There's a significant improvement in walking distance with either intervention or exercise, which is maintained over 18 months or so. What I want you to take from this is that if you look at the mean peak walking distance, it's still not particularly good by time. They go from 4 minutes before they have to stop to 12 minutes before they have to stop. I would not suggest that this is a great cure. This is more up-to-date data. So this is from the Voyager PAD study, looking at patients who had intervention. And what we're looking at here is CLTI versus claudication and their functional status at baseline and then after 1 month of their intervention. The darker color on the bars are patients who felt they had much difficulty or were unable to complete their activities of daily living. And what the authors take from this is in both groups after intervention, we still have a large number of patients who are not able to do their day-to-day tasks. We also have studies that have done longer-term follow-up, such as the Ironic trial. This followed patients out to 5 years after either interventional treatment or exercise training. And you can see at the bottom, there was no change in walking distance between the two groups. And actually, there was no difference in the patient's experience of physiological pain. What seemed to be different was their ability to cope with that pain and push on through it. But this study and many others do show that over-intervention on this group comes with a risk of progression to CLTI and limb loss. So what do NICE recommend? Well, we all know this, optimal best medical therapy, exercise, but what we often don't think about very much are the pharmacological interventions we can offer to improve patient symptoms, vasodilator therapy. Peripheral vasodilators fall in class C04A in the WHO anatomic classification of chemicals. We essentially have 3 commonly investigated and reported choices. Cilostazol, it costs about £40 a month. Naftidofural, it costs about £10 a month. And pentoxifylline, it costs about £20 a month. The idea of all of these is they vasodilate, improve perfusion to muscle, and allow patients to walk further. They've been used for a very long time, and this is a summary of the meta-analyses of all of the randomized trials. And you can see here, MWD is maximal walking distance, and PFWD, the pain-free walking distance. And this is the percentage improvement from baseline. And you can see that naftidofural is much more effective in both of those metrics than any other of the drugs. It is also, as I showed you on the previous slide, very much the cheapest. So in terms of pound per QALY, it is the only one that is shown to be significantly cost effective, and that's why it's the only drug that is supported by the current UK NICE guidelines. Neftodeferol has been around for a very long time. It was first marketed in 1968. How does it work? We don't fully know. It certainly has activity against both vascular cell and platelet 5-HT2 receptors, and also seems to stimulate intracellular ATP production. Individual patient data meta-analysis of just over 1,200 patients shows a relative improvement in both walking distance before pain is experienced and maximal walking distance of around 40%. So we underutilize this drug, but if you look at the bottom, the number needed to treat is 4.5 patients. So this is certainly something we can use much more, which is low risk and certainly should benefit a large number of patients. Now, I'm not talking about secondary prevention in this talk. You have to come back later for that. But there is evidence that good cardiovascular secondary prevention can also have an impact on claudication distance. This is an example from a paper from 20-odd years ago, looking at high dose versus low dose versus no statin in 350 patients with peripheral arterial disease and their walking distance. And you can see the placebo group are the little triangles with the dashed line at the bottom of the graphs, and the statins are the other two groups. Now, the effect is similar in both statin intensity groups, but there is a clear, small but significant increase in walking distance. So this supports the idea that optimal treatment of cardiovascular risk factors can also have an effect on walking. Have we got anything more up to date? Well, about 3 days ago, the PERMIT trial reported. This was looking at metformin, which is the current cure for all vascular ills, on patients with peripheral arterial disease, focused specifically on 6-minute walk test. Unfortunately, there was no impact. But the STRIDE trial earlier this year showed that for Ozempic in patients with PAD and diabetes, over 1 year, there was again a small but significant improvement in walking distance, admittedly only between 8 and 11%. So, conclusion, claudication is really common. Actually, most of these patients are not seen by us, they're managed in the community. Our current treatments at best give moderate benefit. Clearly, best medical therapy and exercise are critical, but I would suggest that vasodilators exist and are useful adjuncts to this, which are probably underutilized across the patch. We can improve optimal best medical therapy by we can improve walking distance with optimization of best medical therapy. There may be a small additional benefit with semaglutide in diabetic patients. And I think in future we need to consider what is the best combination of best medical therapy, exercise, and vasodilators. And of those patients which we do decide to intervene on, who are those who really gain long-term benefit? And we need to make sure we follow patients up long enough to understand if there is a real long-lasting, real-term benefit. Thank you.
Thank you, Professor Bailey. We have time for 1 or 2 questions.
Yeah.
Mark, do you think the reason why people are walking more on Ozempic further is because they're losing weight and they're carrying less weight? And also for the same reason some of the statin users, is that because they're just being looked after better overall and their cardiovascular status?
I think it's a really good question, and I honestly don't think we know the answer. And I suppose there's 2 ways to think about it. One, does it matter? You know, I think for a long time we've looked at biological mechanism and tried to figure out really, really subtle detail. But I think a better approach is to say if things work, we should do them. And I think that the implication of the later trials is that if we do everything well, both the best medical therapy, the walking, and perhaps the right use of vasodilator drugs, we can get people to walk further without doing risky interventional procedures on them, and we can improve.
Yes.
As a district nurse in the community, a lot of I work for Boston as well, so but I saw a lot of patients being put on right at the beginning, and their actual reduction in swelling, I saw actually half when they were put on as well. So I don't know if that correlates with it.
I missed the beginning. Was that for Ozempic?
Yes.
Yeah, I think there probably are multifactorial causes, and I agree, it probably is the improvement of their overall underlying sort of diabetes, metabolic disturbance that's helping. But we should remember that doing those parts right for the right patient may also give them improvements. It's similar to the varicose vein patients losing weight. You know, that will help them.
Okay. Last question, please.
When you're putting patients on naftalifuril, how long do you trial them on it for? You know, at what point do you stop it?
Excellent question. So the general advice is it takes between 3 to 6 months to show an effect if it's going to show an effect, and it doesn't come on immediately. So I would usually do 3 months and see how they respond. I've stopped doing the lower dose and then moving to the higher dose because that never seems to happen. And then at that point, if it doesn't work, stop.
Thank you. I think the course of time we need to move on. Thank you very much.